So, on behalf of UP chapter of Association of Radiation Oncologists of India, we welcome you all. And as we all know, our classes are going on. Head and neck series has been completed. Now, lectures on breast cancer are going on. So today's lecture is based on radiotherapy in early breast cancer. And it's our proud privilege to have Dr. Shagun Misra for this lecture. Dr. Shagun Misra is Associate Professor in Department of Radiotherapy in Sanjay Gandhi PGI Medical Sciences, Lucknow. And as we all know, she is an excellent teacher. And the lectures that I have heard, I can say yes, none other than her would have been better for this lecture. So I welcome you, Dr. Shagun, to continue this lecture. Thank you very much.
At the outset, thank you, UP-AROI, and that's very kind of you, Rashi. I hope that I'm able to deliver and stand up to what you have said. So, without wasting much time, my brief over here, I was given this brief to discuss radiotherapy in early breast cancer, and the learning objectives of today's session is to understand the role of whole breast radiation after breast conservation. What's the rationale of boost? What's the indication of giving post-mastectomy radiotherapy in the context of early breast cancer? Briefly, we'll be talking about hypofractionation. I know there is a separate class on hypofractionation in the next 1 week or so. We'll be discussing about the rationale of accelerated partial breast irradiation. And in these early tumors, is there a case of omission of RTs, a slide on future directions, and a slide on toxicity estimates with modern studies. So what do you understand by early stage breast cancer? And basically, the tumor size, which are less or equal to 5 centimeters, with either a negative axilla or a clinically N1 disease, or a pathologically N1 disease, that is 1 to 3 positive lymph nodes. Basically, they fall into the stage grouping of stage 1 or stage 2 disease. And all these tumors, which present with either less than 5 centimeters or a single palpable axillary node on clinical examination, or 1 to 3 positive nodes, constitute early stage breast cancer. It's very important to understand the burden of such disease in the Indian context. And as you can see in this table, the epidemiology of breast cancer is starkly different as compared to that of the West. The median age of diagnosis for breast cancer in our country is a decade younger. It's 40 to 50 years as compared to 60 to 65 years in the West. Majority of the tumors in the Western countries are less than 5 centimeters, as opposed to a fourth in our country. 2/3 of the patients present with node-negative disease in the Western context, whereas in the Indian context, only a third present with node-negative disease. And this is a very interesting study from various hospital-based cancer registries reported in the Journal of Global Oncology. And what this study informed us is that about nearly 30% of the patients that present to us in the clinic would be in early stage breast cancer. So what are the treatment options? You have local treatment options and systemic treatment options. In terms of local treatment, you have breast conservation therapy, which compromises of margin negative lumpectomy and adjuvant radiation therapy, or a mastectomy with or without radiotherapy. We'll see as to why radiation is indicated. That's the main topic of discussion today. And you give adjuvant systemic therapy depending upon pathological variables, a combination of chemotherapy plus minus hormonal therapy. So what are the surgical options for early stage breast cancer? And mastectomy was, yes, historically, it was one of the standards of care. And you have different types of mastectomy. We moved from radical mastectomy, wherein you would not preserve the pectoralis muscles, to modified radical mastectomy. In modified radical mastectomy, you all must know it means removal of the breast tissue with the skin nipple areola complex, along with the axillary level 1 and level 2 lymph nodes. And here the pectoralis muscles are preserved. You have total mastectomy, wherein you remove the entire breast tissue with the nipple areola complex, but not the lymph nodes in the axilla. They may be addressed with a sentinel lymph node biopsy. And the skin sparing mastectomy, which is very akin to a modified radical mastectomy with preservation of the skin, and is generally performed in conjunction with immediate breast reconstruction. The standard of care currently for at least early stage breast cancer is lumpectomy, which is excision of all the invasive and the non-invasive, that is the in situ component, with a negative margin. And the definition of negative margin has become clearer over the last few years, and no tumor at the inked margin is considered to be negative. And when you see a pathology report, it can vary between 1 to 10 millimeters. And based on the location of the tumor, you have different kind of incisions as suggested by the NSABP, because this can have a bearing on cosmetic outcome. Now, surgical management of the lymph nodes. Evaluation of the axilla is a very important component of staging. About 30% of the clinically negative node patients have positive lymph nodes pathologically. Historically, axillary lymph node dissection was a part of standard surgery, but currently sentinel lymph node biopsy is the standard of care. And in patients who have a positive sentinel lymph node biopsy, as of now, completion axillary lymph node dissection is recommended. And staging the axilla, basically, it helps to define prognosis. And there is some evidence to suggest that, yes, it decreases the risk of axillary recurrence. Now, coming to the main body of my talk, the first component is to understand the role of radiation in the treatment of early breast cancer after conservation surgery and the rationale of boost. So the management of breast cancer underwent a change, a paradigm shift when there was a philosophical change. The Helstedian philosophy was that breast cancer is essentially a local regional disease, and it follows an orderly pattern of spread from local to regional and then distant. And thereby, there was a lot of emphasis on extensive local regional treatments. That's why you had those radical and extended radical mastectomies. It's only when this hypothesis was refuted by Kryles and Keynes, and later on confirmed by Fisher in his experiments, this philosophy that was changed, and breast cancer is considered to be a systemic disease rather than a local regional disease. And then in the 1980s, less extensive surgeries in the form of breast conservation surgery became popular. And it also became popular only when it was topped up with radiotherapy, because the whole breast radiation component compensated for the less extensive surgery. And we'll see how. So a number of trials comparing modified radical mastectomy with breast conservation treatment. BCT, remember, comprises of surgery plus radiotherapy. There were a number of randomized trials and meta-analysis which showed that these treatments are comparable in terms of local control, overall survival, and BCT offers a better cosmetic outcome. So these are these 5-6 trials. They have been reported at a very mature follow-up of 15 to 20 years. And what these trials showed that there were no difference in the local recurrence between mastectomy and breast conservation with the addition of radiation. And there was no compromise in the survival. So the second question comes that, is addition of radiotherapy required at all? And there are a number of trials to this effect, wherein breast conservation surgery alone has been compared with breast conservation surgery plus radiotherapy. And radiotherapy clearly decreases the local recurrence. And this decrease in the local recurrence was statistically significant. The odds of decreasing the local recurrence is roughly half. Although individually these trials did not show that this decrease in the local recurrence conferred a survival advantage. And what's also interesting to see in these trials is that the boost dose was used very varyingly. Some of the trials did use a boost, while others did not use a boost, and it was not known whether boost dose was necessary at all. But what these trials individually suggested that yes, addition of radiotherapy to breast conservation surgery decreases the local recurrence rates. And then we had these meta-analysis from the early breast cancer trialist group, also known as the Oxford analysis. And here, this is an IPD, individual patient database analysis. And this meta-analysis clearly showed that the addition of radiotherapy to breast conservation surgery decreased the risk of local recurrence by nearly half. The majority of the local recurrence, that is the separation of the curve, you can see occurs in the first 5 years. And the absolute benefit is to the tune of 15% at 10 years, and the relative reduction is 50%. And not only so, very interestingly, this trial showed that this decrease in the local recurrence with long-term follow-up also led to increase in survival, both in terms of breast cancer specific fatality or overall mortality. So there was something that was happening that by preventing local recurrence, breast cancer deaths were prevented. And it was so because of the residual disease in the breast was considered to be a harbinger for distant metastases. And by eliminating this residual disease in the breast by way of addition of radiation, there was a survival advantage which could be seen at long-term follow-up. This was the tune of 3% in terms of breast cancer specific mortality, 4% in terms of breast cancer specific mortality, and 3% in terms of overall mortality. And this benefit was seen both for node-positive women, although the magnitude of benefit was greater in node-positive women, as well as that in node-negative women. So from these trials, we clearly know that whole breast radiation is an integral part of breast conservation therapy. It reduces the risk of local recurrence and prevents subsequent mastectomy. For every 4 local recurrences that are avoided at 10 years, we have 1 breast cancer death prevented at 15 years. And that's the ratio of 4:1 that we just saw. So this is a very interesting curve, this hypothesis. On the x-axis, you see the increasing effectiveness of systemic therapy. On the y-axis, you see the benefit of local control on survival. And most of our breast cancer patients would fall in this intermediate risk category. And you can clearly see that as we have effective systemic therapy available, the benefit of local therapy, such as radiation on survival, is going to be more and more profound. So that was about whole breast radiation. And as we saw in the trials, the role of boost was not well elucidated in those trials, as there was a lot of heterogeneity in terms of use of boost in these trials. The local recurrence rates that were quoted were about 1% per year for the first 10 years. The baseline risk of local recurrence in any patient depends on the presence of various prognostic factors. So people thought that dose escalation by way of boost could certainly increase the local control rates. There was some dose response relationship that was seen, but it acts like a double-edged sword. That is, dose escalation by way of boost can affect the cosmesis also adversely, which is a very important endpoint of PCT. So when we talk about the rationale of boost, there is a radiobiological observation that there is a dose-response relationship for breast cancer. There's pathological evidence from various studies which have carefully examined the mastectomy specimens, sectioned them serially, and seen that the higher microscopic tumor burden is seen in proximity to the site of lumpectomy. And of course, there is a clinical observation that most of the failures that do occur after conservation are located close to the primary tumor or in the same quadrant. So these are some studies which basically tell us that there is some evidence of dose response. So for a BED of 75 to 80 gray, the local recurrence quoted in the various trials were to the range of 5 to 10%. And when you look at studies where they have an escalated BED of 85 to 90 gray by way of addition of boost, the local recurrence rates fell down to 5%. And then we have pathological studies, which have clearly shown that the density of residual foci are maximally in and around the gross disease and subclinical disease, which leads to recurrence. The density is maximum within 1 to 2 centimeters of the primary tumor. And coming to the third point, the clinical rationale. Studies have clearly shown in terms of recurrence patterns for breast conservation therapy, most of the recurrences occur in and around the tumor bed or the scalp region. And then came the randomized trials to see as to what is the effect of boost over and above whole breast radiation. This is a famous French trial, where in patients with early stage breast cancer, T1, T2 disease, node positive or negative, less than 3 centimeters, negative margins, where they received whole breast radiation, and followed by whole breast radiation, they received a boost dose of 10 gray in 4 fractions, which was delivered primarily by electrons, versus no boost. The primary endpoint was time to local recurrence, and the secondary endpoint of this trial were overall survival and disease-free survival. And this trial at the median follow-up of 3 years gave an estimated 5-year local recurrence, which was lower with the addition of boost as compared to that of no boost. And this had an impact on the disease-free survival. When they looked into the cosmetic assessment, either by physician-reported or patient-reported outcomes, although they had addition of boost, majority of the patients did report good to excellent cosmesis. However, there was increased risk of telangiectasia, and the reason being that we were using electrons. And this was statistically significant with the use of boost. And the next trial, which is very important, all of us should be knowing about this, is the EORTC boost trial. The 20-year follow-up was reported somewhere in 2015. And the trial basically looked into patients of T1, T2 breast tumors, N0, disease, N0 disease, and who had undergone breast conservation. They received whole breast radiation, and following whole breast radiation, there was a group wherein there was negative margins. These patients were randomized to no boost versus a 16 gray boost. And there was a group of patients who had incomplete excision in terms of focally positive margins or positive margins. They were randomized to 10 gray or 26 gray boost. And remember, the primary endpoint in this trial was not local recurrence rates, but the overall survival. And the secondary endpoints were local control, cosmesis, and fibrosis. And what this trial showed at a median follow-up of about 20 years is that the addition of boost does not add to overall survival. But yes, be it at 10 years or at 20 years, it did lead to a statistically significant decrease in the local recurrence rates. But also, it came at the expense of toxicity, and there was a significant increase in the severe fibrosis from 1.8% to 5% with the addition of boost. What this trial also saw was to look into the effect of local recurrence with respect to age. And very interestingly, this trial showed that the magnitude of benefit was greater in patients younger than 50 years of age, while the magnitude of benefit reduced in patients more than 50 years of age. When you look at the relative benefit across various ages, the relative benefit is the same to the tune of 40%. But because the baseline risk of recurrence is different amongst different age groups, the absolute benefit is different, and it lowers down with increasing age. And not only so, what this trial also showed was that the worsening of cosmesis was significantly higher in patients who were more than 60 years of age with the addition of boost. So the magnitude of benefit in terms of local recurrence was lower, and the toxicity in terms of worsening of cosmesis was higher in patients who were more than 60 years of age. And the study also basically did an analysis to look into what are the pathological factors which impact on the long-term local control. And on multivariate analysis, age, less than 50 years, the presence of addition of boost, and the presence of DCIS was an important factor dictating recurrence with long-term follow-up. What this trial, what these analysis showed, that young age was certainly a risk factor for local recurrence. We already saw that. High-grade invasive tumor was a risk factor for local recurrence for the first 5 years. But DCIS, if it is present in the tumor, it's an ongoing risk factor. And addition of boost certainly decreases the local recurrence rates dramatically in patients with all these risk factors. So let's look into the evidence. Boost radiotherapy improves local control significantly, more so in younger patients. It comes at an increased price. There is severe fibrosis, but is less in a younger patient. The relative benefit of boost dose is similar in all age groups. The absolute gain of boost dose is largest in patients younger than 50 years. Absolute benefit depends upon the baseline risk of recurrence. And there are a number of tumor treatment and pathological factors which help us to determine the baseline risk beyond age. So if you want to optimize your boost, in patients who are 50 or younger, you should be using boost in majority, all of them. But for somebody who is 50 years of age or older, you can possibly optimize your boost by looking into all these factors. So the presence of extensive intraductal component, that is DCIS, a grade 3 tumor, T3, T4 tumor, a triple negative tumor, multicentric tumor, a residual tumor after neoadjuvant chemotherapy would possibly mandate boost after 50 years of age. But if none of these factors are present, it's a grade 1, grade 2 tumor, ER positive tumor, possibly you can consider omitting boost in those patients. A very important point I want to tell the residents is we saw one of the arm of the EORTC trial, wherein patients with incomplete excision were randomized to a lower versus a higher dose. What you should always remember is increased risk in the ipsilateral breast tumor recurrence due to positive margin is never nullified by delivery of boost dose of radiation or delivery of systemic therapy or a favorable biology. So somebody who comes to you with a positive margin has to be sent back for surgical re-excision. Otherwise, the risk of local recurrence is going to be certainly higher. So coming to the second part, that is the indication of post-mastectomy radiotherapy in early breast cancer. And when we talk about mastectomy in early stage breast cancer, it's not currently the standard of care, but yes, you might consider it where expertise is not available, or for that matter, radiation facilities are not available. You have multicentric disease. There is anticipated poor cosmetic outcome with lumpectomy. There are persistent positive margins, diffuse microcalcifications in the entire breast, and have contraindications to radiation therapy in terms of pregnancy. Collagen vascular disease is a relative contraindication. Scleroderma possibly is absolute contraindication. Prior radiation therapy now in the current scenario with the current techniques is also a relative contraindication. So looking into the trials as to the role of radiation after mastectomy in T1, T2, N0 disease. And this is a very interesting retrospective review from the DC, wherein they looked into patients, 1,500 odd patients with T1, T2 tumors and who had undergone mastectomy with clear margins and had not received radiotherapy. At a median follow-up of 7 years, they just wanted to see as to what are the pathological factors which predict the risk of local recurrence in these kind of early tumors. They did a RPA analysis, and from this RPA analysis, what they saw was presence of high-grade LVI positivity, a T2 tumor, or patients who do not receive any systemic therapy in the form of chemotherapy or hormonal therapy for that matter, like TNBC, they generally have a higher risk of local regional recurrence. Now, when we talk about T1, T2, N1 disease, there is very clear-cut evidence for giving radiation in this setting from the EBCTCG analysis, which came in 2014, wherein patients with 1 to 3 positive lymph nodes, post-mastectomy patients, they received radiotherapy versus no radiotherapy, and there was a significant decrease in the local recurrence rates, and this also translated into a survival benefit of 7%. And in these trials for N1 to 3 patients, post-mastectomy, RT gave a significant benefit. The absolute reduction being 16%, 20 years breast cancer mortality reduced to nearly 8%. And for every 2 recurrences prevented, 1 extra person was surviving at 20 years. But these trials were conducted in the era of where the contemporary chemotherapy were not available. So possibly the absolute reductions are likely to be smaller in current day and age. But the recommendation as of now, if you look into the various guidelines, the recommendation is to offer post-mastectomy radiotherapy to all patients who present even for T1, T2 patients who present with even a single positive lymph node. It might change over the coming years, but as of now, the indication is to give RT. And for patients who present with node-negative T1, T2 tumors, there's some guidance from some indices which are available. So this is a Cambridge Post-Mastectomy Index. And anyone who has a score of 3 is considered to be high risk. So if the number of lymph nodes are more than 4, if the tumor size is more than 5, excision margins are closed, the score is 3, and this is considered to be high risk. It requires post-mastectomy radiotherapy. But if the aggregate score, there's a combination of score, is greater or equal to 3, it falls into intermediate risk. If the aggregate score is less than 3, it falls into low risk. So if the aggregate score, that is a combination of different scores, is less than 3, it falls into low risk, and you can omit radiation in such patients. But if the aggregate score is greater than or equal to 3 by combination of factors like the presence of LVI, excision margins, grade, etc., they fall into intermediate risk, and it's a case-to-case discussion. You might consider giving radiotherapy to post-mastectomy radiotherapy to these patients. So what are the risk factors for local or regional recurrence after mastectomy? Positive axillary lymph nodes, T3, T4 tumors, high risk, you give radiotherapy. For T1, T2, node negative, margin negative, they fall into low risk and possibly no radiotherapy. But for T1, T2, and any combination of 2 or 3 such factors, they would fall into intermediate risk, and RT would often be indicated in these patients. So for T1, T2, node positive, there is an indication for RT. T1, T2, node negative, consider factors. You consider LVI, grade, age, whether the patient is ERPR positive or TNBC, T size of 4 centimeters or more. You err on the side of giving radiation. So coming to the third part of the presentation, that is hypofractionated whole breast radiation. So we now have a very good understanding of radiobiology of breast cancer, and a lot of it is because of huge body of work done from UK, wherein we now know that the alpha beta for breast tumor is lower, and so is the case for normal tissue, which we always knew. These are estimates of alpha beta for breast tumor and normal tissue toxicity, and these estimates have been derived from the various trials, the STAR-A and the STAR-B trials. And also these hypofractionation, not only because of radiobiology, it offers it's logistically very feasible by it shortens the overall treatment time and helps patients coming from far off places receive the radiation, reduces the number of fractions on your machine space is created. So it offers many such logistic advantages, and economically it is favorable. So the traditional model of fractionation, we knew that the tumor control had, for tumor control, most of the tumors have an alpha beta greater than 10, and increasing the fraction size does not impact so much on the tumor control, but it had a severe impact on the adverse effects if you increase the fraction size. But the new model of fractionation, especially for breast tumor, clearly we know that for breast cancer, the alpha beta is less than 10 gray, and increasing the fraction size offers a greater degree of cell kill as compared to that of other tumors. So breast cancer is sensitive to fraction size, as are the dose-limiting normal tissues. When you're giving 2 gray per fractions, you spare the breast cancer as much as normal tissues, so there's no advantage. So large fractions were worth testing, but because you are the increase in the dose per fraction also leads to increase in normal tissue toxicity, so the overall dose had to be reduced so that it is not very it does not increase the late adverse effects. And these are the various schedules with your EQT2. And you can see that the EQT2 of these regimens, that's 40 gray in 15 fractions, is close to about 50 gray with some degree of dose reduction. So again, coming back to the logistics, if suppose you use 16 fraction regimen instead of 25 fractions, you would save 900 treatment sessions for 100 patients, and you would treat about 56 additional patients for the same number of fractions. It's very, very, very helpful for a country like ours. We are always constrained in terms of resources. We have long waiting lists, at least in the public sector hospitals. And breast cancer is a very important, it's a common cancer. It represents a major workload in RT departments, and certainly using hypofractionation increases a lot of throughput. So coming to the evidence largely came from the START B and the Canadian trials. So the START A trial tested 2 dose regimens. They were trying to see as to what degree of dose reduction is required. And thereby they had these 2 dose regimens. They were delivered over 5 weeks. The START B trial, the 2.6 gray per fraction over 15 fractions, 40 gray delivered over 3 weeks. The Canadian fractionation regimen is 42.5 in 16 fractions delivered over 3 weeks. And what these trials clearly showed that the 40 gray, 42.5 gray is equivalent to 50 gray in 25 fractions in terms of local control. And amongst these 2 dosing regimens in the START A trial, the 41.6 gray dose was equivalent to the 50 gray in 25. So when we look at the what's the inclusion criteria for these trials, most of these patients were TE1 early stage breast cancer. Majority of patients had conservation surgery. They did not have immediate reconstruction. Only 14% of the patients had received no-radiotherapy, and about 60% of the patients had boost. But when you look at the Canadian trial, none of them had mastectomy, and boost was certainly not delivered in the Canadian trial. And about 20% in the UK trial and 25% in the Canadian trial were less than 50 years of age. And this is again the trials basically demonstrating that the local recurrence rates were not significantly different between the 50 gray and 25 fractions and the hypofractionated regimens. This START B trial, interestingly, not only showed that the local recurrence rates are not different as compared to 15-25, but the cosmetic outcomes were better. So it was milder as compared to 50 gray and 25 fractions. But there was a lot of skepticism, at least in the Indian context, in adopting these trials, because we have younger patients, majority of them would require boost, and a lot of them had mastectomy. Majority of them would receive nodal radiation. So this is a meta-analysis of START pilot, START AB trials, and the subgroup analysis to look into local regional relapse. And what this analysis suggested, that irrespective of the age, the primary surgery, the grade of the tumor, whether boost is delivered, or whether adjuvant chemotherapy is given or not, the local recurrence are not different between the hypofractionated or the conventional fractionated radiation groups. So patients can be certainly safely and effectively treated. It should be considered the standard of care for women with T1, T3, and zero-infant disease treated with breast conservation. Patients with mastectomy and those requiring nodal radiation, yes, you have evidence from the START trials. And recently, a trial from China has been reported, especially looking into post-mastectomy hypofractionated radiotherapy. It seems to be safe. There's no overt increase in the side effects. Neither there is evidence to suggest that there is increase in the local recurrence rates. So coming to the third part of the presentation, that is partial breast radiation. Partial breast irradiation is an approach that treats only the lumpectomy bed with a 1 to 2 centimeter margin rather than the whole breast. And because you're treating a small part of the breast, you can increase the dose per fraction and accelerate the treatment. So that is what is known as accelerated partial breast radiation. And the rationale for partial breast radiation is there's a scientific rationale, clinical evidence to it. The vast majority of recurrences, about 90%, occur in the index quadrant. And only 1 to 3% of the recurrence occur elsewhere in the breast. And these elsewhere recurrences are considered to be new primaries rather than a true recurrence. And these would not have been, the incidence of this elsewhere recurrence is very similar to that of contralateral breast cancer. And they would not have been affected even if you would have added WBRT, that is whole breast radiation. Now, this percentage of elsewhere recurrence, this varies according to the series and the duration of follow-up. We'll see as to why it is important. So because of this, it was thought that treatment, rather than treating the whole breast, we can it can be focused just to the area where there is a highest risk of residual occult disease and chance of recurrence by offering partial breast radiation. So when do we consider partial breast or accelerated partial breast radiation? When there is a minimal risk of recurrence outside the index quadrant. And this risk is determined based on conventional biological and pathological criteria. The volume of the breast that is requiring this radiation is not very large, so that it is able to tolerate this accelerated radiation delivery without serious radiation sequelae, and there is technical feasibility, expertise, and means to deliver the accelerated partial breast radiation. So when partial breast radiation was brought into the clinics, there were several centers who started using APBI in unselected patient population. And because this was a very unselected patient population, the local recurrence rates were very high, exceeding more than 1% per year. And the reason for this was that the patient selection was inadequate, and there was suboptimal treatment technique, and of course, there were lack of appropriate QA procedures. So then a number of guidelines, they came up, and they published this criteria to choose your patients outside the setting of clinical trial. And the majority of the guidelines, the consensus is that you take age more than equal to 50 years, tumor size of less than equal to 3 centimeters, negative surgical margins, negative nodes, no lymphovascular space invasion, although focal LVI is allowed, and the presence of DCI is allowed. So coming to the techniques of APBI, there are a number of techniques: brachytherapy, external beam radiotherapy, and intraoperative radiotherapy. Brachytherapy can be delivered by multicatheter interstitial brachytherapy or balloon catheter brachytherapy. And this multicatheter brachytherapy is one of the most time-tested technique. Following this, the other technique that are commonly used are external beam radiotherapy, either by 3D CRT or IMRT. And there are certain intraoperative radiotherapy techniques, that's target and which uses 50 kV photons, and ELIOT, which uses 9 MeV, 6 to 12 MeV electrons. So coming to the intraoperative radiotherapy techniques, and these are the two intraoperative techniques. Generally, you excise the lump and then you deliver the radiation by way of specialized devices. And it's a single dose of radiation. So for targets, it's 20 gray of radiation delivered at 1 millimeter from the surface of the applicator. Similarly, for ELIOT, the radiation is delivered by electrons. Dose of electron is the doses is a single dose of 21 gray, and they have done some calculations to suggest that this dose is equivalent to EQTT of 50 gray. But a word of caution for these trials: both the trials they were reported, and one of the target A was a non-inferiority trial design, and ELIOT was an equivalence trial of equivalence. Both these trials, although the non-inferiority margin was met, but when you look at the local recurrence rates, they were doubled with the use of target as compared to whole breast radiation. So thereby there is caution while adopting these kind of APBI techniques in the clinic. The time-tested ones are interstitial brachytherapy, we given 34 gray in 10 fractions, 2 fractions per day, 5 days, or brachytherapy by way of Mammosite, very similar fractionation. Or external beam radiotherapy, you can give, mostly it is 3D CRT, and some of the techniques use IMRT, which is a forward planning IMRT that they use. And the dose is 38.5 in 10 fractions given as a BID dose over 5 days. So this is multicatheter brachytherapy. You basically excise the tumor. You can do it operatively and implant the catheters, take the CT scans, draw your targets, and deliver your dose. And the common doses that I use are 34 in 10 BID or 32 in 8, which is now commonly used. And we do have now long-term data available indicating safety, provided it's done in expert hands, plus you appropriately select your patients. And this trial reported in 2017 by Dr. Polgar showed that APBI not only has equivalent local recurrence rates as compared to WBRT, but the toxicity profile of APBI was also favorable. And majority of the patients treated with the APBI, about 70 to 75%, 75 to 80% reported are excellent to good cost basis. So when you look into multicatheter brachytherapy, what are the predictors of toxicity? You have, for cosmetic score, you can have dwell positions, volume receiving 150% of the dose, and dose homogeneity is important. Similarly, for late toxicity, you have these dosimetric predictors, and also for your fat necrosis or late subcutaneous toxicity. So it is operator dependent. You have to keep volume as low as possible. You need to minimize the hotspots, and the uniformity should be high. Your DHI should not be less than 0.7. Need to watch the skin and the chest wall dose. The second form of brachytherapy is a balloon brachytherapy, where you insert a balloon into the cavity, inflate the balloon, and you prescribe the dose about 1 centimeter from the surface of the balloon. It's very important that this balloon conforms to the cavity to be able to treat the cavity walls adequately. And there needs to be an adequate distance between the skin and this prescription. Otherwise, the skin toxicity is going to be higher. And these are some advantages and disadvantages of Mammosite over interstitial implant. Mammosite, it's intraoperative. You go and implant it. It's a short learning curve, simple and reproducible. It's convenient to the patient. The disadvantages are that the treatment planning is less flexible because you have a single catheter, although you have now modifications available. You have multi-catheter available as well. If there's a large size cavities, certainly there are limitations in treating it. You can have high skin doses and there's risk of seroma infection. Coming to external beam APBI, the two most, the commonest technique was actually the 3D CRT, which was used. The commonest regime was 38.5 given over 10 fractions BID over 10 days. And very recently, IMRT in the form of forward planning IMRT is being used 30 gray in 5 fractions, alternate day treatments over 2 weeks. This is also a form of APBI and has reported excellent cosmetic outcomes. The pros of external beam, it's of course you're already using external radiotherapy. There's large clinical experience, it's non-invasive, simple technique, no specialized training or equipment is required. There is evidence to the use of external beam. The disadvantages are that the volumes are generally larger, and the trials have reported higher skin or subcutaneous toxicity and compromised cosmetic outcomes with the use of 3D CRT APBI. And the reason for this compromised toxicity is because probably the 6-hour interfraction interval between the 2 fractions delivered daily for external beam was considered to be inadequate. And the 38.5 in 10 was considered to be a little bit severe in terms of the BED. And more importantly, so there has been an issue with the radiobiological estimates for 3D CRT partial beam radiation, and there is a significant dose volume effect. That is, the margins, because you give a CTV and a PTV, so you have larger volume of normal breast, which is radiated to a dose as compared to any brachytherapy approaches. And this differences in the dose volume parameters could be responsible for this kind of a dose volume effect that we are seeing. So just to give an example, the volume receiving 100% of the dose increases by 1 to 2% for every 5 millimeter increase in the BTV. Similarly, the volume receiving 75%, 50% of the dose increases 6 to 7% for every 5 millimeter increase in the PTV. And 3D CRT certainly results in a significantly larger volume receiving 50% of the dose and 100% of the dose than brachytherapy. So this is a graph which shows that with 3D CRT, the low dose volumes, that's the volume receiving 50% of the doses, is significantly higher, and there is a profound dose volume effect which is responsible for the adverse responsible for the adverse consequences or toxicity that we see with 3D CRT. So be a little bit careful when you're using 3D CRT APBI. And a very interesting way of delivering partial breast radiation was suggested by the UK group. This is the import load trial. Patients receive either 40 gray to the whole breast, will not be focusing on the middle group, or 40 gray to just the partial breast, which was treated with mini tangents. And this technique this was given of 40 gray in 15 fractions over 3 weeks. And this technique has reported very good local recurrence rates and no worsening of cosmesis. These are the randomized studies. The rapid is basically 3D CRT APBI, RTOG and ACBP 39. Again, 3D CRT APBI using a dose of 3.85 BID over 10 fractions. And import low is from the UK group using, it's not accelerated radiation, it's partial breast radiation, wherein you give 40 gray in 15 fractions just to the tumor bed with margins. And these are some dosimetric parameters which need to be kept in mind when you are planning your APBI. And import law used a very simple technique. It used modified tangents, mini tangents, and there was no specific volumetric constraints that were imposed. And the follow-up of these trials suggests that although the local recurrence rates are largely comparable for these groups across the randomized arms, but the cosmetic outcomes are inferior with EBRT, 3D CRT, APBI. Whereas for PBI strategies with protracted fractionation 14-15, the auspices was in fact better as compared to that of 50 grain 25 fractions whole breast. So PBI is a safe and well tolerated therapy. It appears equivalent to whole breast radiation in terms of efficacy and ultimately breast cosmesis. Key is the patient selection. There have been consensus guidelines that help us to guide selection outside the auspices of a clinical trial. Multicatheter brachytherapy comparing whole breast radiation and APBI has produced very encouraging results. It's a very time-tested technique. External beam APBI or partial breast radiation techniques, be careful about these low doses, preferably a once daily regimen. Just like the import law has a better safety profile, you need to have stringent QA to be able to do these kinds of techniques. And possibly there is a group of tumors where if you have a better biological understanding, the local recurrence is so low that we can consider omission of RT altogether. So when we look at the local recurrence rates in the 1980s, they were high and they have been gradually coming down. It's use of better systemic therapy, you have better surgical techniques, availability of radiation. So the local recurrence rates are certainly low in the current era. And people wanted to identify a group of patients as to whether they can consider, especially the elderly subgroup, whether they can consider omission of radiation. These are a group of trials where they randomize patients into tamoxifen alone versus tamoxifen with radiation. And most of the trials have suggested an increase in the statistically significant increase in the local recurrence rates with the omission of radiation in this elderly subgroup as well. And when you look across various trials, some of the trials have been reported at 5 years, others have been reported at 10 years. These are trials of omission of radiation. And clearly, the risk of radiation, the risk of recurrence with the omission of radiation has a linear increase. And if we project this to 10 years, possibly by 10 years, if you follow up these patients, and some of them would be surviving 10 years, your differences in local recurrence would be to the tune of 10%. So no-radiotherapy is not a good option even for the elderly. You can possibly consider this in patients with reduced life expectancy, T1 disease, ERPR positive, who are willing to take endocrine therapy for 5 years. But just remember that in the community setting, the compliance to endocrine therapy is to the tune of about 50%. And of course, you can have a discussion with the patient, and those who are willing to accept a modest higher local recurrence, you might consider omitting them. So age was a very important factor in the past to help us dictate the risk of local recurrence. But now the effect of age in helping us determine the risk of local recurrence with the availability of effective systemic local therapies is diminishing. You have these kind of molecular subtypes to help you guide the risk of local recurrence. You already have been using some of them for guiding the risk of distant recurrence. And there are trials wherein who are using these biomarkers for guiding selection of patients who can be omitted radiation, particularly in the elderly subgroup. And there are also trials which are using genomic markers like Oncotype DX for tailoring the fields of radiation, but these are all experimental. I just wanted to highlight this AGCC 8th edition, and I don't know whether US resistance, you have gone through it, and now you have the T and the end stage. As usual, you have an anatomical stage, which was similar to what the 7th edition reported, and now you have a clinical prognostic stage as well, depending upon the ER, PR, and HER2 receptors. So somebody who has an N2 disease anatomically would fall into stage 3, but N2 disease with ER, PR positive positivity would fall into clinically prognostic stage 2A. So this helps for this basically for guiding prognostication, not for selecting your therapy. Last slide on understanding the incremental risk of toxicity after breast radiotherapy, and a very interesting study again from the early breast cooperative trialist group. And toxicities are real. The rates are small, and the doses to the normal structure with current modern techniques have certainly been reduced. So the most feared morbidity is certainly cardiac toxicity. The incidence with modern techniques is to the tune of about 0.3% at 10-15 years. It's increased in smokers. Similarly, lung cancer, the incidence of lung cancer in the first 10 years is not different as compared to that of general population. It's only after 10 years that the odds of developing lung cancer is higher, and it's more so in smokers. The incidence of pneumonitis, even with the addition of regional nodal radiation, is very low, to the tune of 1%. Lymphedema, the radiation unfortunately was always thought to be the major cause causing lymphedema, but now we understand and know it very well that axillary lymph node dissection is one of the major causes. After axillary lymph node dissection, the incidence of lymphedema is somewhere between 24 to 25%, and with the addition of radiotherapy over and above axillary dissection, this risk increases to about 30%. So it's a 3% incremental risk. Shoulder stiffness, it's doubtful. One of the trials did report that the range of arm movements are affected with the addition of regional nodal radiation. Contralateral breast cancer risk is less than 1%, and the risk of esophagitis is 20% with 3D CRT. Esophageal cancer less than 1%. Hypothyroidism, again, the data is not very clear because it's a single lobe of the thyroid that you are treating, and the clear guidance is not there as to whether the addition of regional nodal radiation adds to hypothyroidism. So thank you very much for your kind attention, and would be happy to take any questions.
Good evening, Dr. Shagun. Am I audible?
Yes, you are.
Okay, I'm Dr. Sajal. I'm thankful to Dr. Rashi for giving me a chance to be a panelist on this prestigious seminar. Doctor, I have a question. There was a patient. I faced a technical challenge while planning a case. So a T4 lesion, which was involving skin, with axillary lymph node, which was N2, and this lady was given neoadjuvant chemotherapy at an outside center, and she showed an excellent response. Now, after getting an excellent response, patient was counseled between MRM and BCS. This patient was triple negative as well. So between MRM and BCS, patient opted for BCS, and after getting the BCS done, patient was referred to me for post-operative radiation. So how should I manage? Means what kind, like I should send the patient for resurgery, or I should manage this as per as early breast cancer, where there is a post BCS, I'll give a boost, or I should manage it as locally advanced breast cancer, like treating a chest wall with IMC, axilla, and SCF.
So, if your concern is regarding the safety of doing a conservation in locally advanced breast cancer case. So there is some data, at least from the Tata Hospital, which suggests that yes, breast conservation is feasible in the locally advanced subgroup. In terms of radiation, I mean, there are two components to radiation. You have the breast radiation and the regional nodal radiation. So you need to treat certainly the whole breast. And in terms of nodal radiation, you need to address the supraclavicular fossa. But IMN is somewhat doubtful. So unless and until you don't see a positive lymph node on your planning CT scan, or there was a positive lymph nodes on a pre-operative CT or PET that might have been done, you generally would not treat the internal mammary node, and boost is certainly required.
Okay. Thank you. Actually, this patient had nodes prior to the surgery and prior to the chemo as well. So that's what I told. So this patient may have merited IMN as well, IMN and axilla. That was. Thank you.
So, Dr. Shagun, we have a few questions. What should be the dose accepted on plan evaluation on the left side when you are giving 40-15?
So you have again guidance from the START trialist group. So in terms of doses to the lungs and the heart, this is what you are asking?
Yeah. So if there is a left-sided breast cancer and we have given RT, if we are giving 40-15, what should be my heart dose? So basically heart dose would be LAD dose as well as the left heart dose.
So generally the recommended doses are a mean heart dose of less than 2.5 gray and mean LAD dose of less than 20 gray. So that's what the recommendations are, and they hold true for both the conventional fractionation as well as for hypofractionation.
So then would you put in, how would you achieve it? Like the next question comes is getting such a low dose for the left heart, would you go in with the 3D CRT or with image guidance?
So I did not talk about heart sparing techniques because of lack of time. And so you have MLCs. So by use of MLCs, you can now shield the heart. And if it is an unfavorable location, especially lower inner quadrant tumor, there, when you're trying to shield the heart, you're shielding the target or your primary quadrant as well. Then, of course, a deep inspiratory breath hold is something that can be offered to the patient. So more than image guidance, it's a motion strategy and the use of shields.
Yeah, so we have, I think, one full talk on that, motion management, image guidance in breast.
Yes.
So I think that will help us.
Yes.
Now, there are two questions on the same issue is, what is the significance of the central lung distance and its related risk of percentage risk of pneumonitis?
So let me tell you this, the use of central lung distance and the maximum heart distance was largely in the era when we were using 2D planning techniques. So you did not have a volumetric estimate. That's why you use these distances to give you an estimate as to what would be the percentage of lung that would be irradiated based on the central lung distance, 1 centimeters, 2 centimeters, or 3 centimeters. You have an estimate as to if it is 1 centimeter, it's less than 15%, more than 3 centimeters, more than 30%. But now with the current treatment planning techniques, you do have the volumetric estimates. So probably the need of a CLD or MHD, you might measure it, but it might, it's better to have your DVH and evaluate your plan there. That gives you a better estimate of the doses to the OARs.
Okay, thank you. And Dr. Shagun, a few more questions are there. What is the role of boost in hypofractionated RT and BCT or post PCT or post PMRT?
So, in case of breast conservation, irrespective of whether you're using hypofractionation or conventional fractionation, the indications of giving the boost remain the same. They do not change. So for somebody who is 50 years and above, ERPR positive, grade 1, grade 2 disease, negative margins, you can possibly consider omission of boost. But for a younger patient and somebody with T3, T4, grade 3 tumors, that's the kind of tumors we see over here, boost needs to be considered. And generally what we are doing we are giving it as a in sequence. That is, after 40 grade 15, you give it as a sequential strategy. And now there are studies which have also looked into simultaneous integrated boost as well. So these are the two ways of giving boost, and your risks are determined based on your age and other pathological factors. You can give it in sequence, and if you have the techniques, if you have the quality assurance done, you can give it as a simultaneous integrated boost.
Thank you, Dr. Shagun. There's another question. What would you choose, 3D CRT or VMAT?
So it's a very, very pertinent question. And generally, you would try and avoid inverse planning in a case of breast cancer because you want to avoid the low doses to the OARs. So the preference is towards the use of 3D CRT. And if at all you're not able to achieve your homogeneity, then a way to go forward is to use a field-in-field or a forward planning IMRT.
Great. So then in cases where breast reconstruction has happened, how would you boost it?
So you need to understand as to why breast reconstruction. A breast reconstruction, provided the patient has undergone a mastectomy. If the reconstruction is, mostly reconstructions are done in those settings following a mastectomy. And in that setting, a boost dose of radiation is not required. It's just the whole breast radiation, the whole reconstructed breast. You need to ensure that the skin is properly covered.
Great. And also, what is the, I think you covered it, but just I think there's a question, so we'll accept it. What is the median time between BCS and RT? And if a person has skipped that post BCS RT, what do we do then if he comes later?
So generally, the median time is you need the scar and the seroma to settle a little bit. So 4 to 6 weeks is a good time. And the maximum time is reported, where RT is considered to be beneficial, that's about 6 months.
Okay, there are a few more questions. I think you're getting a lot of questions and you had a very good attendance also, Dr. Shagun. So should I take those questions? There are some questions on high nodal burden as well as locally advanced breast cancer, and we have talks on those topics. So those are still. So I don't know. I'll take the nodal question because that's more pertinent. So does high nodal burden preclude whole breast irradiation, or can we give partial breast, APBI, or boost?
So if you have a higher nodal burden, radiation certainly is in order, but you do not consider these patients for partial breast radiation. It's always whole breast radiation. So I didn't understand this question quite very much.
I know. I think the question should have been, if there's a high nodal burden, do we add is it partial breast or whole breast?
It's always whole breast because the presence of axillary lymph nodes, remember, it dictates the risk of local recurrence. So you cannot omit radiating the breast.
Okay. how to delineate the boost volume after oncoplastic breast surgery?
I think this is a topic altogether as to
Yeah.
how do you identify the boost volumes, and the best way is you ask your surgeons, you train your surgeons to place clips, and they provide a very good guidance. But after oncoplasty, it's always a challenge for even for us. Every case we need to discuss with the surgeon. Uh, Generally, what is recommended is before the rotation, you need to place the clips at the tumor bed so that the clips don't get rotated along with your breast surgery. But yes, it's certainly a challenge identifying a boost cavity following oncoplasty breast surgery.
So I think I'll end it here. Thank you, Dr. Shagun.
Thank
There
you
are
so very
2-3
much.
more questions, but they'll be covered in the future classes. So we have those classes scheduled. Um, Again, thank you again, Dr. Shagun.
Thank
It
you.
was a
Thank you.
wonderful class.
Thank
And
you. Thank you so very much.
thank you.